all you want to know about the NIAGARA trial in one slide. It's a phase 3 randomized controlled trial which included muscle invasive bladder cancer patients who are cisplatin eligible. If you want to travel to Niagara Falls, you need to be fit. You need to be fit enough to take cisplatin. That is the inclusion criteria. It had 2 arms, 4 cycles gem-cis durva followed by radical cystectomy followed by 8 cycles of adjuvant durvalumab versus 4 cycle gem-cis followed by radical cystectomy. Right. Remember, the control arm should have received adjuvant pembro or nivo if there was no pathological complete response. But it was not given because the trial initiated before the results were out. It is a positive trial. The primary endpoint was pathological complete response and event-free survival. PATCR better, 3325, but not statistically significant. 1 year EFS was significantly different, 8 percentage points, 6860, overall survival 8275, 7 percentage point difference, hazard ratios 0.68, 0.75. Note the Kaplan-Meier curve of overall survival. Note that the separation in curves happen as early as 6 weeks, that is in the neoadjuvant setting itself and not later on. That means neoadjuvant durvalumab adds benefit, not just the adjuvant one, right? So coming on to few important points of this trial, it included 40 to 60 creatinine clearance as cisplatin eligible. However, it was only 18% patients. In this patients, cisplatin was given in divided doses as 35 per meter squared day 1, day 8 along with GEM. What about durvalumab? So the mechanism is it blocks the interaction of PDL1 with CD8. So the dose was 1500 3 weekly in the neoadjuvant, whereas the same dose 4 weekly in the adjuvant setting. Very important, urothelial carcinoma pure 85%. Overall survival was 0.72 hazard ratio, whereas urothelial carcinoma with other histological subtypes combined mixed histology at 15% patients, and the overall survival hazard ratio is 0.52. So here we have an evidence for giving gem-cis durva for mixed histologies. What about the stage? T2N0 was 40% patients. Even there, the benefit was there. However, the hazard ratio was 0.8. N0 was 95% patients. Hazard ratio impressive for overall survival. What about PDL1? It was done by SP263. The estimation was not like PPS, CPS. It was complex. It was not positive, negative. It was high versus low. They used something like a tumor cell immune cell algorithm. 75% were PDL1 high. However, the benefit was more pronounced. Like it was 0.62 hazard ratio for low PDL1 and 0.7 for high, right? Now coming on to the comparator arm of the Checkmate 274 and Ambassador trials. The NIVO trial did not have, had placebo as a comparator, whereas Ambassador trial, Pembro, did not have any comparator. Conclusions. NIAGARA trial is practice changing because it improves EFS and OS at 1 year. The EFS curves separate as early as 6 weeks. So NACT-IO combination adds benefit in the neoadjuvant setting. If a patient is cisplatin eligible, NIAGARA should be preferred over the adjuvant Checkmate 274 Ambassador trials because of the early separation at 6 weeks. The benefits are seen even in T2N0 and mixed histologies. PDL1 is not predictive of benefit. Well, this picture makes you to remember treating bladder cancer is like driving an ambassador to Niagara Falls to play chess and ending up with a checkmate. Just to remember three important trials: Ambassador, Niagara, and Checkmate 274. Thank you.